Thank you very much, Dr. Wood, for your informative talk. And I want to thank you in advance for all the questions you are going to answer in the next couple of minutes. For those of you that are on the webinar, you can type your questions in the chat box at the right side of your screen. And if we run out of time, unanswered questions will be posted on our online discussion forum. So any questions from the room while we wait for some to come in from, oh, look at the hands.
Okay, yes. In Nova, let's just take Nova Scotia because we're here. Do you see in the summary, what's the timeline for Nova Scotia approving to pay for combination trials?
So the question is, what is the timeline for kind of drug approval, funding, and things like that? And so the process is a drug or drug combination is submitted to Health Canada, and it's approved based on efficacy, does it work? And then if it does, it goes to this other Pan-Canadian Oncology Drug Review, PCODR, and they present the data on efficacy, ethics, and economics. And so, for example, if you have a treatment or a tumor, which kidney cancer was in 2005, that had no other good treatment options, your drug or the data is seen more favorable than if you have 10 treatment options, for example. The bar is higher. And so after PCODR, they make a recommendation, and then it goes to another committee, and the PCODR recommendation is always, yeah, ethics look good. Yes, efficacy looks good. The economics don't look good because unfortunately these are profoundly expensive drugs. And so then it goes to another meeting, another group, and they look more into the economics of it. And each province is represented, and it's closed door meetings because there's something called the list price of a drug, and there's the actual price you actually end up paying. And in the old days, it was each province negotiated their own price, and that didn't make a lot of sense. So now it's done at a Canadian level, and minus Quebec, so not Quebec. And that they have negotiations with the drug company, et cetera, and decide if they're going to fund it or not. And we are not privy to that at all. I'm personally not. The PCODR stage, for whether it's approved, has a big patient component input and clinician. So that's where, again, Kidney Cancer Canada will often email me and say, you know, we're looking for patients that have had nivolumab to be able to help with the submission and things like that. I always ask your permission. I don't give your names without checking with you. But anybody can go on any time and help with those submissions if they want to when they're due. So then if this other committee decides to say yes, then it goes to each province. Now are we going to fund it? And some provinces are a lot more streamlined than others. So BC is kind of who we'd all want to be. You know, they have a very fast process. And they get an answer, whether yes or no, they get the answer quickly, because at least you get an answer. Nova Scotia, New Brunswick, PEI are definitely slower, and it takes longer. And I don't know how to speed it up. And again, that's the other good thing about Kidney Cancer Canada is both advocacy and support. So one of the reasons many of you'll have had a handout from me on their brochure, because I suggest everybody sign up to be a member of Kidney Cancer Canada, because then when we are going downtown to advocate for drugs, I can say, you know, X number of Nova Scotians support this through Kidney Cancer Canada. Intravenous drugs are handled different than oral drugs. And again, if any of you have been Kidney Cancer Canada members, you know over the last 2 years that they've had a lot of, they've requested help with a campaign called Can Certainty. And Can Certainty is trying to prove the point that you should advocate for the point that it shouldn't matter if you're IV or oral drug, you should get the same coverage. In the Western provinces of Canada, they're handled the exact same. So if an IV drug is approved, an oral drug is approved. In Atlantic Canada, oral drugs go through private insurance or pharmacare. So if you're under 65 and uninsured, you theoretically have no coverage for any of these drugs. So the hope one day, and that the government recently did put some more money into that in this budget to help with that. So the answer is, I don't know. there's 3 hoops it has to get through before it ever comes even to Nova Scotia. And then the hoops here aren't always transparent, and the duration is variable. Yes.
We have some questions from some of our online viewers.
Great.
Paul and Mary Ann want to know what research is being done to find out what patients will respond to a specific treatment. I think it's called biomarkers. And the follow-up question, is there research specific to finding those biomarkers that is not clinical trials?
A lot of the research is linked to clinical trials. And so again, as I mentioned, when you are enrolled in a clinical trial, you have the option, and you can opt out if you want in most trials, to donate a piece of your original tissue to the study. And then there's extra urine tests, extra blood tests. And so what they're looking at is there something pre the treatment that we can then look back at and say, these people responded really well. So most of it's linked to clinical trials, because most of it's linked to, did this treatment help this particular patient? So there have been a lot of advances in breast cancer with regards to that. So again, looking at genetic profiles of individual tumors and saying, given this genetic profile, we think you would benefit a lot more from treatment A versus not at all. So there's definitely advances in oncology. We're still a long way from kidney cancer, but it's all ongoing. And then there are labs that are not treatment related. So again, taking a whole bunch of kidney tumors, looking at them and just looking at outcomes. So again, as I mentioned on that last one, with Samra's research, she's found 4 mutations, that if you have those 4 mutations, you do very, very poorly. So maybe they're the ones that we should be the most aggressive with. Whereas in her studies, if you've got only 1 mutation, a very specific mutation, only that one, you probably don't need anything at all. So it is coming. It's not prime time now.
I got more. I mean, not me personally. This comes from MS. I just have the initials. Are there any studies in chromophobes?
So chromophobe tumors do very, very well. And it's even less than 5% of all kidney cancers. Chromophobes arrive from a different part of the kidney than clear cell and papillary. And so the answer is, as far as I know, there's no phase 3 trials, and I don't think there's any phase 2, partly because the patient population is just so low with that metastasize, which is a good thing. It's a good problem to have. Another one?
I've got a question from Leslie. Leslie had a Whipple operation in 2012 and is on Sutent since then and has now developed diabetes. Would she do better on immunotherapy?
So what a Whipple's procedure is removing the pancreas. So some kidney cancers can metastasize anywhere. If you have a metastasis in the pancreas, it's almost always from kidney. So kidney goes there, and patients with pancreatic mets actually tend to do very well. They have a slower natural history, interestingly, and nobody knows why. And so sometimes if that's the only site of metastases, it does make sense to remove the pancreas, just like if somebody only had 1 lesion in their lung, you would remove that lump, or 1 lesion in their adrenal gland, if you can surgically take it out. Removing the pancreas, the job of the pancreas is to make insulin and other hormones. So if you take out the pancreas fully, you become diabetic. There's 100%, everybody does. And so I would definitely, so that's one point. The second, so it's not the Sutent that caused the diabetes, it's the pancreas surgery is what my point was. And at the end of the day, there's still not an overabundance of treatment options in kidney cancer. So if you're on a treatment and it's working, I would not change. The reason you change is it's truly intolerable, even despite dose adjustments, schedule changes, a whole bunch of other things. But you stop it when it's not working, because you can't guarantee the next one's going to work. And from a funding point of view, in most provinces, once you stop one and go to another, you can't go back. So you have to use the treatment you're on for as long as possible, because your options are limited after. And the reason for that is because if you stop a drug because of progression, so it's drug A you're on for a while and then your cancer progresses, and then you go to drug B and you progress, it hasn't been studied going back to A, and it doesn't make sense that if you progressed on initially that you'd actually go back to it. If it's for intolerance, it's another thing. But that's why it's not funded. So I sometimes make government sound out to be horrible in terms of funding and stuff, but there is a reason for some things as well. And it's not cheap therapy, you know? So again, whatever we spend from a public purse point of view, whatever we spend on X, you don't get for Y. So in Nova Scotia, do you want good schools or do you want, you know, all provinces have many competing interests. And so what we try to do is fund things and approve things that we have scientific data on. One more question from the outside?
We do. This is a question from Glenda. Since Dr. Wood is the primary oncologist in Atlantic Canada managing pharmaceutical trials, do you consult with other local oncologists that treat kidney cancer when starting a trial to identify candidates? If not, how does a patient get to consult with you?
Yeah, and so the Moncton also has a lot of clinical trials. So patients from New Brunswick, and so we all end up at the same meetings and things, at, you know, different things. So we talk about who's got what trial open and stuff like that. So again, for example, when these drugs first came out for melanoma, Moncton was the key player. So we would send patients up to Moncton. I've certainly had patients from New Brunswick and PEI and clinical trials from Sydney. One of the difficulties is, and more so even now with these therapies, is they are a lot of visits. And so if you're driving from PEI in February and you have to get over here every 2 weeks, it can be difficult. So just Canada's logistics sometimes make it very difficult, versus if you're in the UK, everybody's within 2 hours of everybody, you know, here. And that's the problem. So obviously we work around that and stuff like that, but we certainly do talk amongst ourselves all the time. And St. John also has clinical trials. More so now, their GU team is building up, gender urinary team is building up. And so St. John, Moncton, and Halifax would all have trials. And again, hopefully you're using Kidney Cancer Canada website, because along with the clinical trials, it has the locations of each one. So again, if patients are, it's often family members more than the patient themselves, are searching up things, and they can actually, it will have the location of each study across Canada. And we've sent people outside of Atlantic as well, you know, to Quebec or wherever for clinical trials as well. Obviously that requires a lot more cost and logistics from a patient point of view. Yes.
Do you only see patients who are doing clinical trials, or do you see?
So the question is, do I only see patients that are doing clinical trials? Absolutely not. The huge majority of our patients are not on clinical trials. In Canada, I think the goal is, and I might be misquoting here, so don't hold me to it, but 5%. So the huge majority of patients get standard of care.
Okay. I had a kidney removed, and when I went to follow-up appointment, Dr. O'Malley, who I'm sure you know, he asked me if I was interested in looking into clinical trial, and I said yes. And he said he would send whatever on and what paperwork he had to send on. And I've never heard anything. Would that have gone to you?
So the question was, if the surgeon said they were going to refer you on for a clinical trial and you haven't heard, something happened. So the cancer centers, in almost all cancer centers in Atlantic Canada, have a central referral office. So the central referral office, and often there'll be different tumor sites, so GU, gastrointestinal, lung. So those people get all the referrals, they get all the paperwork that's needed, they make a file up for us, and we see people as a new patient. So and that stands for anything, whether you refer to a cardiologist or a neurologist, if you haven't heard, something's up, because.
Well, I would have seen him March 22nd. So am I expecting to hear something too soon?
So the question was, when should you hear about an appointment with a specialist? So in oncology, it would be very rare that it would be more than 2 weeks that you hear. You may not get seen in 2 weeks, but it would be very rare that you would not hear about it.
What should I do? Who should I?
So if you're ever, for anybody, again, if you're ever referred to a doctor and you haven't heard, you have to go back to the referring doctor. So to touch base with their office, which I know is difficult sometimes, and say, did the referral get sent? And you know, the problem is, when we have medical students and things with us now, the fact that we still rely on fax machines in 2018, because you can send a fax and it could have fallen on the floor in a wind gust, right? Or faxes have no confirmation. So again, you could fax something to someone and the guy's gone for a month on holidays and you don't know that. So the new generation just go, oh my goodness, can you not do this electronically and have some confirmation?
You get confirmation you sent the fax, but not confirmation that they actually got it.
Well, and interestingly, a lot of fax machines now, because of paper, just sheer volume, you don't even get the confirmation now anymore.
I didn't want to harass his office, right? I keep thinking, should I have heard?
So somebody was
His
mentioning
office is really good.
they don't want to harass somebody, but again, and you are your own best advocate. You know, only you can advocate for yourself. And we might get annoyed. No, just kidding. No, I mean, you know, you're your only person. So advocate away.
I will.
Yeah.
Thank you.
Another question.
I have not a question, but a message from Kidney Cancer Canada Executive Director, Stephen Andrew. He says, "Good evening, everyone. I watched today's webinar from the International Kidney Cancer Coalition Conference in Mexico City. I am so taken with the presentations and thank Dr. Lori and Debbie for spending time with us. We truly value their support and that you took time to join us. Thank you, Karen, Mona, and our entire team for assisting and to QE2 Health Sciences. Stephen."
Thank you. I'm thinking next year we should get invited to Mexico City, though. I don't know. It's kind of, there's still snow on the ground here today. So we'd much rather be, I think, in Mexico City with you. So if you need some representatives for the next meeting, I think I got a bunch here that would gladly come down.
Hi, my question's regarding personalized precision ways of treating anybody that has, I suppose what I'm trying to say is for testing for proteins, enzymes in your cancer cells. If you're looking at the type of drugs or therapies, would it be advisable for the patients to get any type of testing for DNA or genetics that might help you decide which drugs that you would issue to the person without them going through taking one and that not working and then changing to the other drug? Would that be advisable for an oncologist?
So that's a great question. So again, can you study somebody's tumor, see the genetic alterations, and base your therapy based on that?
Mm-hmm.
So there are studies ongoing, and unfortunately, so Vancouver and Toronto are the main players right now in that avenue, and they're done on a protocol. So again, a clinical trial. So where they're looking at, let's just say 15 genetic mutations that happen to have a target. Because the other key is you don't want to find a mutation. Well, if you find a mutation that you don't have a drug to target, it doesn't really matter if you know about it in 2018. It might make a difference in 2020 if we've got new drugs. So what they're doing is looking at those, no matter what the tumor type is. So if your kidney cancer happened to have an EGFR mutation, which is common in lung cancer, then should you treat with an EGFR-based therapy? So those protocols are ongoing. Toronto has published their results. And one of the problems is trying to tease out the results because, again, think of 25 different tumor types and 10 different mutations and 9 different treatments. So then looking at the outcomes. So say you used an EGFR mutation in 2 people with kidney cancer and it worked in one and didn't work in one. What does that mean? In the US, at some of the academic centers, they are doing it as routine. I don't think yet we know if it makes a difference yet. So I would, for example, an EGFR, I would hate for a patient to get an EGFR drug when sunitinib, I know, works in a third of people. So until it's actually proven to be beneficial, that that's the right way to do, I don't think we're there yet. I think we will be one day. Here they are doing some work in lung cancer. So they're taking some lung cancers and doing a 15 gene panel to look at a bunch of different mutations. And part of the issue as well is what are even the incidence of these mutations? Is it 1% or is it 10%? Is Nova Scotia the same as Mexico City? So again, the idea being that some of these probably have a geographic variation as well. So for example, though, a success story is in lung cancer. So a genetic mutation in lung cancer called ELK is only in about 1% of lung cancer patients. But there's a really good targeted therapy to that, and they've proven in studies that drugs that target that mutation markedly change outcomes. The problem is we're just not there in kidney cancer yet. Maybe it's because it's so heterogeneous that, again, we just haven't found a drug that will hit a whole bunch of different targets at once. So as of today, 2018, no. But that's exactly where research is. Yeah. So right now, no. I mean, no. Right now, no, as standard of care. If we had a study ongoing, and again, we are hoping to soon open one in prostate cancer across the country. So again, look for 4 to 6 mutations and then base the therapy depending on the results of each of those mutations. Therapies like that existed for a long time. Breast cancer, we look in breast cancer for estrogen receptors and progesterone receptors. If you're ER or PR positive, you got that therapy and it changed outcomes. If you were negative, you didn't. And we've been doing those treatments for decades. But that was an easy one because, again, that was a very common and it was often just single. In kidney cancer, I think one of the problems is there's just so much going on. And it's not going to be just one in most patients. And that's that term, that driver mutation. Which is the mutation actually driving it from the beginning? And that's the one we have to figure out, or ones we have to figure out. I'm not a geneticist, molecular geneticist.
The protein that is used to hide the cancer from your cells,
Yep.
from your immune cells, is it a specific type of protein that could be managed through any dietary means? The same as somebody who has diabetes stays away from sugar.
Yeah, so a great question. So the question is the abnormal proteins that are putting the brake on the immune system, is there some way that you can self-modulate that or do something to, because again, empowerment, advocacy empowerment, like what can you do? So the answer as of today is no. And it seems to be, so no, again, do we know something more in 5 years? I sure hope so, but as of today, there's nothing that we know. Now, we do know that certain lifestyle modifications increase your overall health in general, but in terms of actually affecting one protein, no. Yes.
I just feel so popular. This is a question from John in PEI. He says, I've been on 3 different treatments, Votrient, Nevo, and now Sutent. Would I ever be eligible for a trial if and when the Sutent fails?
So that would be called a 4th-line trial. So those have existed in the past. As far as I know, currently, there are no phase 3 4th-line trials. And that's where some patients go on to what's called the phase 1 or the phase 2 study, where the eligibility is a lot looser. So again, many people that go on a phase 1 study have been through all the standard therapies. So again, they're looking like, will this brand new drug help me? Unfortunately, in Atlantic Canada, we don't run phase 1 studies. They're very time intensive and resource intensive. So for example, patients will often need to be in a chemo unit for a 24-hour period because you need blood samples at 2 hours, 4 hours, 6 hours later and things like that. And we don't have that capability here. So there are those. What I can tell you though, John, so Health Canada should soon be approving cabozantinib for post-Sutent patients or post-Sutent or pazopanib patients, Votrient. So soon there may be a Health Canada approved drug for you. One issue is, how is it funded in PEI? So unfortunately, funding in PEI has been a little bit more difficult. Right now, we actually do have some access to that drug for some people that need it through a special program. So you should hopefully soon have a Health Canada approved drug for that, for 4th line.
Hi, doctor. Is there any proven correlation between pH levels and cancer? Or is that just a myth?
So it's a very good question. Does the pH make a difference? And the answer is we don't know. There's no hard data, but then you look at something like the gut bacteria, And so again, is it related to that somehow? And there are certainly in the lay literature, there's a lot out there of taking acidic things like hydrogen peroxide or vinegar and things, or taking alkaline things like baking soda. And there's some people that take both, which to me counterbalances it a bit, but there's no hard data that it makes a difference. There is for urinary tract infections, and there are for people with kidney stones where changing the pH matters, but not for kidney cancer that we know of in 2018 on April 12th.
I just want to know if I should have baking soda or lemon juice.
Baking soda or lemon juice? Yeah, and we don't know. And so I'd say a little bit of both. But have a lemonade, and what can you, baking soda, tonic water? Is that alkaline, I think? Yeah. There are some people that have been on clinical trials. I don't know if anybody has any specific questions about anybody that's been on a clinical trial, that I don't think would mind speaking if there was any specific questions. Any other questions from outside? Okay.
One more quick one.
Yep, and one more from here.
Can you explain again the difference between AB and IB?
Yeah, so the question was, can you explain the difference between NIBs and MABs? So sunitinib, pazopanib, axitinib all end in the same ending. And what that means is that they target whatever pathway they're targeting happens inside the cell. And the target is usually something called a tyrosine kinase, but again, it works inside the cell. MABs stand for monoclonal antibody. So a monoclonal antibody is something that attaches to something so it can't attach to what it's supposed to. So they work outside the cell so that, for example, your bad growth factor can't attach to your cancer cell and cause it to grow more. So these MABs, which is bevacizumab, attaches to it outside the cell so that pathway can never get activated. So it's all about these pathways. We've got these pathways that are turned on in cancer, and you want to turn them off. So you turn them off inside the cell with IBs and outside the cell with MABs. Monoclonal antibodies used to be from mice. We made them, and so they were first used, I might get my history of medicine wrong here, but they were used extensively in lymphomas. And you can imagine introducing something from a mouse into you, there were a lot of allergic reactions. So now and then they were combined mice-human, and now they're almost all humanized. So that's why the reactions to them are much, much less than they used to be, because your body doesn't see it as foreign. So it's very, very rare. And I think in Halifax, we've only seen one allergic reaction to all of these drugs, which is good news. Yeah.
Coming in.
And did you have one as well?
Just one question about when the cancer moves from the kidney to another organ, why, I don't remember the reason why it goes into the lung.
So the question is, when the cancer cells travel from the kidney and go somewhere else, why there? So why can your cancer cells metastasize or spread via the lymph system and the blood system? And if you've got a cancer cell traveling in your blood, why does it go to one spot in your lung and not one spot in your liver, for example? And we don't know. And what we do know is the body can clear some of them you're on your own. But why does it set up shop in one spot, not the other? It's not well understood. And why can some people set up shop in one spot and then it just not grow after that at all? We don't know the answer to that either.
I have a question from Amanda. She wants to know, how many treatments can a kidney cancer patient receive?
So how many treatments can a kidney cancer patient receive? So one of the good things, again, is, so we had first line with sunitinib or pazopanib. We had second line with everolimus and axitinib. And then after that, with all this explosion of studies, which again is a good thing. So let's just say Nivo is better than everolimus. Cabo is better than everolimus, but we don't know Nivo compared to Cabo, for example. So then when the people look at these results, they say, so does that mean that only one's ever going to work, or could they work in sequence? And from a government point of view, you have to prove that it works in sequence. And so right now in Canada, you can either get Nivo or Cabo. You can't get both unless you have private insurance, and then sometimes the private insurance will cover it. And the reason for that is because that's not how it was studied. They work two different ways, so it makes sense that it would probably work in sequence, but we don't know that. So in terms of drugs, there would be 5 different drugs that have activity in large studies. That doesn't mean you're going to get 5 different funded drugs in Canada, unfortunately. For some reason, for some of them it makes sense, and for others it may not make sense. So it's probably not the answer you wanted. But in terms of data from clinical trials, there's 5 lines of therapy that a person could possibly get.
My mom and I are listening from BC and mainland Nova Scotia. My mom has been living with stage 4 kidney cancer for over 4 years. Lately, she's been having a lot of UTIs. Is this a normal reaction? She's on Voltaren.
So infections are not common with the sunitinib and Votrient and whatever. Those drugs, it's not common. So I would look for other causes for it. With chemotherapy, we always worry about infections because often your immune system, your white count is low, but your white count may go a little bit low with these drugs, but not put you at risk of infection. So I would look at different causes.
In the past, I've heard some patients were able to revisit a drug if they had done well on it after a long period. Is that fact? Is it possible?
So the question is, it's called recycled drugs. So if you were on a drug 5 years ago and now you've had treatment B, C, and D, can you go back to A? And again, the answer is we don't know. We've certainly done it, and we've seen some people where it's worked and some people it hasn't. So for example, if you were on a VEGF pathway blocker and it stopped working, and then you tried different pathways, maybe over time that VEGF pathway starts to get activated again, and maybe you can go back to that. But there's no randomized large phase 3 data on it. We've done it patient by patient, and sometimes it's worked and sometimes it hasn't. But when you say to somebody after they've had 4 years without sunitinib, do you want to go back to sunitinib? Some may not say yes, but some will eagerly jump at the chance.
Really? Because of side effects.
Because of side effects.
Okay, I think